We've got a really great webinar today. I'm really excited about it. Some new thinking around how to engage general practice in alcohol and drug work. And we're here as well with our friends and colleagues from the Brisbane North PHN. I'm Nicole Lee. I'm the CEO of 360 Edge. I'll just start by acknowledging the traditional owners of the lands that we're all on today. I'm on the land of the Boonwurrung people in Naarm in Melbourne, and we acknowledge that we're on Aboriginal land that was never ceded and pay our respects to elders past and present. I'm super pleased to introduce the webinar today. One of my very first jobs as a baby psychologist, baby researcher, was at Queensland Health working on the fourth phase of the development of the audit questionnaire. So this was the implementation phase. And we really came up against a lot of barriers trying to introduce the audit into general practice at that time, getting general practitioners to screen and do brief interventions and a whole range of other things. And that was like 35 years ago. So we're still grappling with that question. But during some work we did with the combined Queensland PHNs, we came up with a slightly different way of thinking about GP engagement. And so I'll hand over to Tim to tell you a little bit about that. Tim's our head of health systems development at 360 Edge. He's going to give a quick presentation, and then we also have the lovely Gai Lemon on from Brisbane North PHN. Anyone who's been around for any length of time in the AOD sector will know Gai. But currently she's the program development lead for alcohol and drugs at the Brisbane North PHN. So I'll hand over to you, Tim.
Thanks, Nicole. So primary practice has an important role in alcohol and drugs. They are the first line of support for people seeking assistance for their alcohol and other drug use, and they also provide specialist treatments such as prescribing. But as Nicole was saying, engaging primary practice in alcohol and other drugs has always been challenging. I recall one of my first projects, probably not as long as Nicole's was, but it was around 6 years ago in Victoria, and it focused on pharmacotherapy prescribers and dispensers. And in that, there were many people working very hard on so many initiatives to ensure a sufficient number. 6 years on from that, there are still many people working extremely hard across the country, albeit in an even more challenging environment. And we hear the pain and frustration. We felt this in our recent work with the Queensland PHNs. The PHNs were putting on a range of alcohol and other drug training and education, but with limited uptake. We heard that an example of a vignette that got 5 views in 3 months. And there's this underlying anxiety of not having enough prescribers. But as Nicole was saying, from our recent work, we're seeing it with renewed optimism and excitement. One of the original questions in the work was, does the training need to be tailored to local needs? So the data did show some variation, but what it was reminding us of was something bigger. Alcohol and smoking prevalence are high in every catchment. This example here is alcohol, where on average, a third of the 14 plus population have a risk score indicating that they would benefit from some support. We also noted the relatively smaller number of people that had illicit or pharmaceutical drug issues that they needed help with. And we know that providing support has significant benefit. Tobacco and alcohol use are the first and fifth leading risk factors contributing to disease burden in Australia. But the barriers to engaging general GPs into alcohol and other drug work, such as having the time, the confidence and knowledge, the remuneration, and then overlaying the stigma and stereotypes associated with alcohol and drugs on that, these are well known and haven't changed for many years. And as we said, they're even more challenging now in a stretched health system. So we had a light bulb moment. We had to look at the issue differently. The current range of valid initiatives that everyone is pursuing, they're resulting in incremental change, and they're targeting those GPs with an interest. So instead, we need to think about GPs' readiness to engage. like we would for someone looking to change their relationship with alcohol and drug use. The training and education offerings have assumed that GPs are ready to engage, but not every general practitioner is at the same level of readiness. So we need to be more strategic in the way we engage, or stealth-like. So in our recent work, there was talk about stealthily bringing alcohol and other drugs into the consciousness. So we turned it into an acronym. And this acronym is really about strategic and targeted engagement, but it's also about holistic care. GPs are seeing a number of patients every day with hidden alcohol and other drug issues that could benefit from some support. It's a whole of health view. So using this thinking, we developed a new strategic approach to engaging GPs based on their level of interest. It's step care for GPs. The current offerings and initiatives are geared to those with a high level of interest. They're mostly geared to that group. Those who want to engage deeply with things like pharmacotherapy prescribing. But this is a relatively small group. Most GPs fit into the other two tiers that we've developed. One of those is those that have a bit of interest, some interest, and might do some screening and brief intervention work, or refer to other health providers if they have the right tools easily accessible to them, or the right support and guidance. So for this group, we suggest making upskilling easy for them. So instead of focusing just the training and education just on alcohol and other drugs, have a focus on skills such as motivational interviewing and topics of interest such as related health areas like liver health, vaping, medicinal cannabis, and incorporating alcohol and other drugs from a whole of person and a whole of practice perspective. The other tier is GPs that have very little or no interest, or maybe they just don't know enough yet to be interested. For this group, just some knowledge and information in a stealthy way. So dropping some facts and figures into education and training related to other health topics. That framework that we just talked about then was more around how we engage with primary practice and GPs. But there's some internal work as well. Alcohol and other drugs is a broader health issue, but often seen in public health management as a specialist area. Alcohol and other drug teams are often to the side. We see an opportunity to build alcohol and other drug knowledge in other health areas so that it can be incorporated into planned and opportunistic engagement, which we know is really effective. This whole of health, whole of person approach is important, remembering that 1/3 of the 14 plus population would benefit from some support related to their alcohol, which is a top 5 risk factor for burden of disease. Like all the past initiatives, including the ones I saw 6 years ago, we believe that what we do now and in the future will benefit from applying this approach. Thanks, and back to you, Nicole.
Right, thank you. Thanks, Tim. So if any of you have questions or comments, please, you can pop them in the chat, but there's also a Q&A. You'll see a Q&A button there. You can pop your questions in there. And while you're thinking about that and posting your questions, I'll just go to Gay and ask you if you could just tell us a little bit more from the Queensland PHN side about what drove you to engage 360 Edge to do this primary care capacity building.
As Tim has outlined, we've obviously have a remit here at PHNs to do a lot of work with our general practitioners, and particularly in bringing them along on that journey of health. And we know that they have been seriously overburdened by everything that's been happening in the last few years with COVID. We also know that there are many competing interests for GPs, so it's quite tricky in terms of getting them to come along to education, as was outlined. One of the main points of impetus, I think, though, was when we were struggling, particularly in Brisbane North and Brisbane South regions, with the loss of some ORT prescribers. And what happened was, and certainly what it highlighted, was that there was several practitioners who, by and large, had the the wealth of knowledge around opioid replacement therapies, and also were the ones that were looking after quite large cohorts of people that needed to access those services. So when those practitioners essentially fell over, for want of a better word, what it highlighted again was that we're in a very precarious position here. We have people who are needing ORT, but with a deficit of prescribers. It really showed just how necessary it was to try and get more GPs to appreciate the importance of taking on board people who are requiring this form of treatment. And in conversations with a number of different agencies, the sort of statistics that were coming up was that if a GP across the state, if one GP could take on 5 clients requiring opioid replacement therapies, or even addressing the need for alcohol and other drug treatment, then the burden would be essentially shared across all the GPs in the state. And we know that this isn't just a statewide issue. This is something that we're seeing right across Australia, certainly from the information that I'm receiving. And so that's why we look to 360 Edge to come on board and, I guess, interrogate some of that knowledge around why is it that it is so tricky to have GPs engage. And for the reasons that Tim raised previously in his presentation, we're seeing that there are a lot of disinhibitors towards getting people to step up into this space. And as a consequence, yes, 360 Edge came up with this wonderful tiered structure of stealth, which I really like because I love a sexy name.
It was such like a light bulb when we came up with it, wasn't it? And
It
like,
was. And what surprises me, Nicole, in all of this is that it's fundamental to understand that you meet people where they are at in terms of their education or their need. And I'm truly surprised that we haven't come across that before. And I don't know whether it's because we tend to raise GPs so high and have them almost in this godlike domain, but they are simply people, and their education needs are exactly the same as everybody's. And and so, like, understanding that there are different levels of engagement and knowledge and wherewithal to engage with the AOD knowledge, it just makes such common sense. So kudos to you for for figuring it out.
it's really, in hindsight, seems so simple because it's the same concepts that we apply to clients and patients and service users. So it's it's like, I don't know why we didn't think of this 30 years ago too.
Yeah, exactly. And again, like, when we're talking about service users, we know that the stigma and discrimination that they experience on a daily basis, particularly when they're going to access health-related services. So this sort of approach is really hopeful of breaking down some of that as well.
Yeah, great. And were there any like really particular key insights that you gained aside from this massive light bulb that we've all kind of figured out? Were there any particular insights that you gathered during the project that would apply more broadly?
Knowing the data and the data that you were able to pull together, and seeing the reality of how it was spread across the regions, I think that was really insightful as well. And I think using that data as an education tool as well for general practice, because it can be sometimes, I think, that there may be a bit of a disjointure between what is perceived to be the real issue in a region compared to what the reality is. And for example, we know and have known for a little while that there are certain areas within the Brisbane North catchment that have specific prescription opioid issues, yet because of the nature of the population there, upper middle class, predominantly white, so the questions aren't asked, or it's just presupposed. And it may well be that, you know, this overuse of prescription drugs is because of chronic pain issues, for example. Having that data was really useful, and being able to translate that into training and applicable understandings about what GPs could anticipate in that space. So, whilst it isn't something we haven't done yet, I really do believe that that will be one of the ways forward. And even having that notion that there are differing levels of engagement, different tiers of engagement by GPs, and their knowledge and capacity it seems so simple and so straightforward. However, it's such a rich insight. And yeah, sometimes what's in plain sight is sometimes invisible. Can't see the forest for the trees.
Yeah, absolutely. And what are the next steps forward then for the PHNs in Queensland now that we've got this new kind of framework?
So the wonderful thing about this is that we've managed to start putting some things in place. So, for example, there's been a development of opioid replacement therapies information resources by Insight, our training colleagues as part of Queensland Health. And again, it's also expanding on that tier-like approach to GP education. So what it's looking at is there's some very base level resources that can be provided to people who are accessing GPs around naloxone use and also access to opioid replacement therapies and the like. Educating GPs very basically around what is needed in that space, encouraging those that are very interested to look at potentially becoming prescribers, but also sharing that idea of shared care in those regions where that's a possibility. So, for example, here in Brisbane North, we have a wonderful shared care arrangement between the AODs in HHS and in general practice. So there's an opportunity for GPs to work closely with their colleagues in hospitals around managing and supporting people who are needing ORT. So the GP looks after the general holistic health of the individual and oversees their treatment. However, should there ever need to be greater regulation, for want of a better word, they go back to the hospital for that. So, and then there's varying levels of that are being trialled around the state as well. So other areas in Queensland are also doing some of that already. So there's a lot of that sort of thing that's happening. We're looking also to about how to better engage with PHN staff that have connections with GPs. And this was one of the recommendations that came from the work that you did. And the idea there is, again, to use what we know by engaging GPs in that stealth way through conversation. And a lot of us know that that's often the best way to engage anybody, particularly when you're looking to break down those barriers around knowledge, stigma, discrimination, those kinds of things, making it real and personable. So if we have PHN staff who have knowledge around alcohol and other drugs, they can then, in their conversations with their general practice, they can begin to seed some of those ideas.
Yeah, that's a really great point that the people that are trying to engage with the GPs also need to feel very comfortable with the whole idea of it and be across all of the issues. And the more we can get GPs comfortable with the idea of raising the issue, asking the question, the more likely they will and will get better coverage that way as well.
Mm,
I've got a couple of questions, quite a few questions.
great.
So the first one's probably to you, Tim. Just wondering if, you've done a bit of work in this area, whether this is a Queensland issue or whether you've heard of this elsewhere.
Yeah, recently there's been a lot more feedback from other jurisdictions on work that they're pursuing around primary practice engagement or planning to pursue. So it's definitely not a Queensland thing. As we know, it's been around for a while, and so we're hopeful that this work that we're presenting today will support those initiatives now and into the future.
Yeah, great. This might be to either of you, maybe to Gay. How do you get other people who are providing training for GPs to kind of get on board with this idea? Because we hear this all the time from a whole range of other organisations that provide training. They put on training for GPs, you know, often at great cost, and, you know, 5 people show up. Really.
Yeah, it's $64,000 question. I think it's about working with your training providers in the area. And I think so many of us experience that frustration when we're trying very much to upskill any practitioners, really, but particularly when we see the lack of response or the lack of engagement by our general practice in this space. And I'm super keen to see some of this turnaround at like obviously getting GPs to engage much more with alcohol and other drugs, mental health, suicide prevention. The whole thing really needs to start at the training point where they're learning to be these highly skilled practitioners that we have in all our areas. In terms of the training pathways and trying to encourage trainers, I think developing really good relationships with those training providers is part of that. And I think also to breaking down some of the pre-existing expectations within our own services, because exactly as we've seen with this project and the whole notion of a stealth approach, there's still, I think, a presumption in our organisations that this is the only way to go, that this form of education, you must educate, and at all costs, doesn't matter if it costs you a squillion to have 5 people come along, but it's so inefficient. And I think we need to also educate ourselves. So I think coming from within and then understanding why people aren't engaging, or the how we can make it more engaging, that's part of it. But yeah, definitely the relationship building is a key part of it.
Yeah, right. So another question from Anonymous. Just they say I come across people ready to change alcohol use, but they're reluctant to go to their GPs due to lack of trust, and they seem to need a lot of guidance. Where else can they go for the support they need?
With alcohol and other drugs?
Yeah.
It depending which part of the country they're coming from, the Alcohol and Drug Information Service is always a really good point of contact. So ADIS, I believe that's national. Here in Queensland, ADIS is very well connected with a range of different services. They have warm referral processes established. I'm not clear on what's happening in other states, but ADIS would certainly be what I would suggest as the first port of call. There's also some useful online apps and things like that, like Hello Sunday Morning. For some people, they might find that really useful. It's really about knowing what's available in your area.
Yeah, so the ADIS is the Queensland name for, there's one in every state, and there's a national alcohol and other drug hotline now that kind of feeds into all of the states depending where you're calling from. So if you look that up, you'll find that the telephone service that will be able to direct you to the right place. Next question is, what feedback are you getting from GPs so far, and how are you finding the level of uptake or interest in kind of broader package training incorporating alcohol and other drug considerations within education, like MI or liver disease? In our region, there's so much education on offer, the GPs have to be very selective.
Gee, that's interesting, with more rather than less education.
Mm.
Currently, at the moment, because this is very new, we haven't been able to put anything in place at the moment, but hopefully I'll be able to get back to you at some stage in the next 12 months or so to see just how that is being enacted. So it's very early days at the moment, and I think certainly doing our internal education. The other suggestions that came out of the report as well is ensuring that we have common health pathways that GPs can access that are able to support general practice in that. I'm not sure if that's a national initiative, but it's something that can be supported by many PHNs, although not all have oversight of the health pathways. If you're not familiar with those, they're fundamentally a process that a GP can access online, and they can see what the pathway is for them to refer a patient onto a substance use service. Primary sense, which is often commonly used as the, I guess, the data collection tool for general practice. Currently, it doesn't have, I believe, a reminder in place to redo the alcohol testing a year from when it's initially taken. So working in that space, doing some stuff like that. So there's some sort of small ticket items, but they have the potential to sort of chip away and hopefully create an environment where GPs are reminded more regularly that these are things that need to happen.
Yeah, that's the
Yeah.
trick, isn't it? Just kind of, that's the whole stealth idea, is just kind of slipping it in as much as possible wherever it can fit
Yeah,
comfortably.
absolutely. Yep.
Yeah, and that was one of the recommendations as well, is to look at the training offerings that are currently in place, and looking to see where you could just slip it in, but also planning those new training sessions if it's in another area of say the PHN, looking at mental health, how you could potentially integrate alcohol and drugs into that in some way. So it's but to do that internal education and the people in the mental health teams feeling more comfortable around talking about alcohol and other drugs and having it front of mind to incorporate it, because we can't just keep adding more training. We almost need to condense it. So the more that we can stealthily put in, we could see that benefit come through.
And one of the things I think that you mentioned, Tim, in the H element of stealth is about that holistic approach. And I think what you've highlighted there is key to that. And it's not only in mental health. Like, if you look at chronic disease, chronic illness, particularly, for example, chronic pain. So people, and we know that back injuries and things like that are fairly significant issues for a great many Australians. And so if you're looking at that and the use of substances to manage that pain, we're still talking about drugs. So it mightn't be the alcohol, but we're still talking about drugs. And I think when we think about drugs, in our own minds, we need to apply a bit of that stealth, in that we're not just talking about the illicits. We're talking about a whole range of drugs and drug use, and particularly with prescription drugs, which we know are significant concerns for people of my age cohort, for example. And so if you can educate in amongst that kind of chronic illness approach around alcohol and other drugs, including prescription drugs, that's a great step forward, because often GPs will be, particularly pain management, because it's something that's, as I said, it's quite common. So if GPs can get some education about pain management, slip in a little bit there about people who might be using their pain management medications in problematic ways. And what you've done then is, literally by stealth, you've educated. And I think this is what we need to be doing. It's that value, as sandwiching, for want of a better word, drugs and alcohol between those sort of chronic disease issues, so that's what needs to happen.
And it is really how GPs often get information in small bites, and that's how they need to, because that's the model that they work from. They can't take a whole day out to do a workshop usually, but if they can get it in small pieces here and there, then it all kind of builds up. I've just got two last questions before we finish up, and they're both related, so I'm kind of related. I've related them to. So I'll ask them kind of together. So one of them is about ACHOs and whether how you can engage with GPs in those settings, and the other one's about GPs through the Head to Health organisations and how you might engage those GPs and whether there's other considerations. And I presume by extension, a whole range of GPs in other kind of specific settings.
I think this is again where it's really useful in our areas. I know we have Head to Health here, and a great many PHNs do. So again, educating the staff that are on board there around alcohol and other drugs, it's almost an osmotic process. So educating them, same thing with the ACHOs. If you've got staff that are directly dealing with the ACHOs as well, doing it through that means. And I think sometimes it's not even going directly to the GPs. It's starting it with practice managers. I think, you know, practice managers need to be educated about this as well, because they have the ear of your GPs, you know. And if there can be something convincing, like a case put forward that's convincing that addressing this will, you know, raise the bottom line for a business, because let's face it, GPs are businesses these days. It's not like we used to see in the 1950s movies, you know, somebody hangs a shingle and they're there for the rest of their life. But it is a business, and I think it's important that we understand this, and not just to sort of, again, it's about re-educating ourselves about what it is and who they are, GPs, and the practices in which they work. They are a business. So raising that bottom line might well mean educating people that aren't necessarily GPs, looking at your practice managers, your front of house reception staff, you know, like your practice nurses, that kind of thing, giving them the cachet to raise that with the GP, to say, you know, maybe we should be looking at this because we're seeing there's a need. This will bring more people in. And all the meantime, like, we know that MBS rebates are not fabulous. However, there can be ways and means of addressing that as well. And again, linking that to chronic illness can sometimes be the way. So there are ways and means. We just need to think strategically and laterally, I think.
Great.
Yeah.
All right. Well, we should probably finish up there. Come to our time. So thank you both for your time. Thanks everyone for your attendance. There was a question which I answered by text, but this recording will be available probably sometime next week, and everyone who registered will get a link sent to it, so you can rewatch it if you desire. Thanks everyone.
Thank you.